Thank you so much for the kind introduction, Bob, and thank you so much, Dr. Shahand, for inviting me to be here. I always very happy to be interacting here with our patients, and something that I want to let you know that I remember telling earlier to one of the who attended here is like, please ask any questions you may have. We're here for you. We're here to answer any questions, any doubts. Everybody here is very happy to talk to you. So the people who are here and presenting to you, we're really passionate about what we're doing, and we really want to help you. So please don't hesitate to ask any questions. And with that, as Bob said, I'm going to discuss the rarest forms of neuroendocrine tumors. And yes, he said it's likely not applicable to you because most of the patients or attendees here may have either a pancreas neuroendocrine tumor or a small bowel neuroendocrine tumors. This is a more rare neuroendocrine tumors that arise in the adrenal gland, and we're going to talk a little bit about that. Okay, so these are called pheochromocytomas and paragangliomas. So let me tell you a little bit of what these tumors are. So as you can see here, we have the adrenal gland. So the adrenal gland are on top of the kidney. If you cut the adrenal gland in half, it has two layers, as you can see here. You have the outer layer, who produces a series of hormones that we're not going to discuss today, but we have the inner layer that produces a hormone called adrenaline. So that's the responsible or your fight and flight response. Now, if there is a tumor arising here from this part of the adrenal gland, it's called pheochromocytoma, which is basically a tumor arising from the adrenal gland. At the same time, because these are coming from the nerves, from the central nervous system, we also have other central nervous system change here, as we can see here, which can be anywhere from the neck all the way down to the abdomen and pelvic area. And as you can see, these are the green dots, which is nerves, a series of change of nerves, and those are called paragangliomas. If there is a tumor arising from this either change of nerve change, that's called paragangliomas. Just to summarize, if we have a tumor arising from the adrenal gland, it's called pheochromocytoma. You have a tumor arising from outside of the adrenal gland, it's called paraganglioma. Sorry. Let me just go here. I'm going too fast. Okay. Now, this is sometimes can be a little bit more complex, these pheochromocytomas and paragangliomas, because depending on where they're coming from, as I said earlier, it could either arise from the adrenal gland, so it could be anywhere from the head, abdomen, and pelvic area. But depending on where the tumors arise, if you have a tumor arising from the neck area, that's a different kind of nerve that are associated with these head and neck paragangliomas, and those are called parasympathetic paragangliomas. But the important thing to remember about this is that these tumors, they usually do not produce any hormones. Now, if you have tumors arising from the chest, abdomen, and pelvis, those are the tumors that produce hormones. And because, as I discussed earlier, if you have a tumor that is producing this excess of adrenaline, this fight and flight response, as you can see, this excess of hormones can be associated with high blood pressure, increase in heart rate, and also sweating as well. So there's a series of symptoms associated with this excess of hormones. And as we can see more commonly, we can see that most of the more commonly the pheochromocytomas in the adrenal glands account for 80 or 85% of all cases, and less common are the paragangliomas. Now, an important fact about this, and we're later going to discuss about if neuroendocrine tumors are hereditary, because I think that's one of the questions as well that I hear from my patients, whether I have a neuroendocrine tumors, what is the risk that my kids may have a neuroendocrine tumors, and we're going to discuss a little bit about that. But these pheochromocytomas and paragangliomas, up to 45% may be associated with a genetic mutation that may be passed into generations as well. And that's something to keep in mind, and it's important to keep in mind. We say that more commonly are the pheochromocytomas, as we can see here, compared to the paragangliomas, which we say is outside of the adrenal gland, which can be anywhere from the neck, chest, abdomen, and pelvis. And sometimes when the pheochromocytomas are present in adrenal gland, 10% of the times can also be found bilaterally, as we can see here, and only up to 25% are malignant, so meaning that they have the capacity to metastasize and go to other places. Now, let's talk a little bit about hereditary syndromes or familial syndromes. As I discussed earlier, up to 45% of patients with pheochromocytomas and paragangliomas may be associated with a cancer predisposition syndrome or familial syndrome. And these are the most common syndromes associated with pheochromocytomas and paragangliomas. There is a condition called multiple endocrine neoplasia type 2A and 2B. And the reason why there are two of them is because they may have different clinical manifestations associated with MEN2, which is different from MEN1. And that's something that we need to make the difference between MEN1 and MEN2 because they have very two different clinical manifestations associated with the syndrome. And we're going to talk a little bit later about MEN1, but in terms of MEN2, there is a increased risk to develop pheochromocytomas as well as paragangliomas, and that's the reason why it's within the familial syndromes associated with pheopara. The other one is von Hippel-Lindau. So von Hippel-Lindau is also associated with pheochromocytomas and paragangliomas, but something about von Hippel-Lindau is that it also has an association with pancreas neuroendocrine tumors, and we're going to discuss a little bit about that. Now, neurofibromatosis is another condition associated with pheochromocytomas and paragangliomas, and is also associated with pancreas neuroendocrine tumors, and also we're going to discuss about this. So I think it's important, even for patients that have the diagnosis of neuroendocrine tumors, depending on what the age was presented. Sometimes me personally, I like to send my patients to a genetic counselor and then look for other conditions that may be associated with these familial syndromes. And then the familial or hereditary paraganglioma, these patients only have hereditary paragangliomas, and there are genes associated with that. The reason why I'm mentioning these genes is because these genes are the ones that may, if there is a chance, a 50% chance that you have the mutation, you can pass the mutations to the kids, and the kids can develop tumors. At the same time, these mutations also has the highest risk of metastatic disease or the behavior that can go to other places as well. And we're not going to go into details about that because it may not be applicable to you, but I'm happy to answer any questions as well if you want to learn more about this. Now, genetic counselor is important in patients. Any patient that has a diagnosis of pheochromocytoma and paraganglioma, all of them, without exceptions, they need to see a genetic consultant. And the reason why is because, as I said earlier, up to 45%, 40 and 45% of patients with pheopara may have a familial syndrome associated with that. And because of that, they need the genetic counselor to do the appropriate genetic testing, as well as when to do imaging studies or what we call surveillance scans. And that's the reason why it's important. But also, a genetic counselor in patient with pheopara can help us establish the risk to develop other tumors. Either pheochromocytomas and paragangliomas can help us understand that based on the mutation, whether they can also have a recurrence of the tumor or they can have also a metastatic behavior, or also if they have any other tumor associated with the condition. And we can discuss a little bit about that as well. Now, when to suspect the pheopara, because I think that's a question that we also need to clarify. I know that maybe for some of you, pheochromocytoma and paraganglioma may be like, oh, this is the first time I heard that. So, but what is that? And as I discussed, it's a tumor in the adrenal gland. But when do we suspect pheochromocytomas and paragangliomas? Is whenever we have signs and symptoms related to catecholamine excess, and that can be high blood pressure, increase in heart rate, sweating as well, feeling nervous, feeling anxious, and that's a very common symptoms of catecholamine excess. And again, these hormones are responsible for your fight and flight response, and because of that, these symptoms may be exacerbated. It can also happen that whenever you have suddenly an increase in the blood pressure that is caused by either a drug that you may have taken, and then depending that you don't know that you took, for example, steroids, and then your blood pressure went very high. Or sometimes it can happen that we see very high blood pressures during a procedures that require anesthesia or surgery. And that's something that whenever we have this, we need to suspect pheochromocytomas and perigangliomas. Whenever somebody has high blood pressure and there's a lot of variability in the blood pressure, that's something that we need to consider as well. If in the imaging studies, they say something on the scans, they say we found something in the adrenal gland, and then also has these other symptoms like high blood pressure, together with this finding on the scans, then we can also suspect with pheochromocytomas and perigangliomas. Difficulty controlling the blood pressure. Some of our patients have 3, 4 different antihypertensive medications and still very difficult to control. That's another indication to suspect PHEO-PARA. Personal family history, as well, we discussed up to 45% may have a familial predisposition to develop pheochromocytomas and perigangliomas, and as well any other cancer predisposition syndrome associated with PHEO-PARA, such as von Hippel-Lando, MEN2, A or B, and NF, neurofibromatosis type 1, and we'll discuss more about that. Now, how do we diagnose pheochromocytoma and periganglioma? We do what we call a biochemical testing or hormonal testing. So basically, this is we do either a blood test or we do a 24-hour urine test. I'm sure some of you may be familiar with the 24-hour urine via PHEO. So we also have a 24-hour urine for catecholamines and metanephrines. We also have a plasma test or blood test, similarly to PHEO. Now we have a plasma PHEO that is also available. And something similarly to patients with small bowel neuroendocrine tumors that produces serotonin that we can measure either on the blood as well in the urine. Similarly, we also do that for patients with pheochromocytomas and perigangliomas. There are certain medications, too, that may cause an elevation of these hormones without being a true indication of pheochromocytomas and perigangliomas. We call that a false positive results, meaning that their hormones is high, but there is no evidence of tumors. Sometimes may be related because of medications that somebody may take, like some antidepressants or some Xanax or some even smoking or coffee 24 hours prior to the testing. They can cause a false elevation of these tests. So that's important to know if we do any of this biochemical testing to make sure that this is something that we need to discuss with the doctors to see if there is any changes that needs to be done on that. So now, imaging studies is very important. Earlier today, you discussed about the different PET scans, 68 gallium DOTA scans, 64 copper DOTA scans, and like all of you here, so the patients here that are attending this meeting, you're familiar with this type of scan. Very similar for PHEO-PARA, DOTA scan is actually the best scan to diagnose pheochromocytomas and perigangliomas. And because this is the best diagnostic scan, as you learned earlier, in order to be eligible to get PRRT with 177 lutetium, DOTA or Lutathera, so we need to have a positive scan. And you may ask, well, if for my neuroendocrine tumors, either from the pancreas or from the GI, can I get Lutathera? And the answer is yes, as we discussed earlier. Patients with pheochromocytomas can also get Lutathera, and yes, they can't. And that's the reason why we have actually a study at the NIH that provides Lutathera for patients with pheochromocytomas and perigangliomas. So we have a patient here, for example, that has this mass. And as you can see, after 2 cycles of Lutathera, we can see that the tumor definitely decreased in size. And that's something that we do recommend Lutathera in patients with pheochromocytomas and perigangliomas. In terms of how we see the response, so the clinical benefit is very similar to neuroendocrine tumors, and we also see very similar side effects as with the other neuroendocrine tumors. So this is something important to keep in mind. That said, Lutathera is not approved for patients with pheochromocytomas and perigangliomas. Some insurance companies are able to approve it, but that's something that we need to discuss, and we're doing the study to also extend the approval of this agent in patients with PHEO-PARA. Now, MIBG, so there was the first approved agent for this very rare neuroendocrine tumor was this MIBG. And MIBG is I'm sorry for the name, it's a complicated name, it's methiodine benzylguanidine, so short for MIBG, which is a radiopharmaceutical use both for imaging studies, so we need to have a positive MIBG scan, and then if it is positive, then we treat the patients with this agent. very similar concept to 177 lutetium dotatate Lutathera. So you need to have a positive Gallium scan in order to get Lutathera. Similar to in this situation, you need to have a positive MIVG scan in order to get MIVG treatment. And it's usually considered in those patients that have very elevated blood pressure, the hormones is very high, and those patients who don't have an MIVG positive scan. That said, sadly, the company that produced this agent discontinue its FDA-approved radiopharmaceutical due to insufficient uptake, meaning that there was not that many hospitals that were requiring this treatment, as well as the high manufacturing costs. And because of that, MIVG treatment is no longer available, unfortunately. That said, we still have Lutathera as an option, but that's sad for these rare tumor types. And as you can see, there is so much work that needs to be done for these patients. Now, chemotherapy is also used for patients with pheochromocytomas and paragangliomas. When do we use chemotherapy? Chemotherapy is for those patients that have very large volume of tumors. Also, when they have many different places as well, and they're very large as well, or they have symptoms related to this bulk of tumors, as well as those patients that we see that they're rapidly growing, that the biology has changed, and then the situation we recommend chemotherapy. This is the chemotherapy regimen that is indicated for patients with pheochromocytomas and paragangliomas, and this is usually via IV. And temozolomide is another chemotherapy. Temozolomide is also given in patients with neuroendocrine tumors, especially with pancreas neuroendocrine tumors, in combination with capecitabine. And as you can see, this is an oral therapy that we give. Now, and then in terms of the tyrosine kinase, what are the tyrosine kinase? And I'm sure they discussed earlier, because tyrosine kinase is also used in patients with neuroendocrine tumors, either pancreas or small bowel neuroendocrine tumors. But what tyrosine kinase do is they block the blood vessel supply going into the tumor. So this is just an example of what, these tumors may produce substance, and this substance can make also growth these vessels that can feed the tumor. So by giving this type of drugs, what they do, they block the blood vessel supply going into the tumor, and that's the idea of, giving this therapy. Now, very similar to GI and pancreas neuroendocrine tumors, for pancreas neuroendocrine tumors, sunitinib is the one that has been approved for pancreas, but there are other tyrosine kinase that we have used for the treatment of either pancreas or GI neuroendocrine tumors. The other one is called cabozantinib, and another drug in the same family is called lenvatinib. So I'm sure that you have heard earlier about the different TKIs used for this tumor type. And then when do we use these type of therapies? For those patients that when we have given chemotherapy, that there is still growth after chemotherapy, so that will be an indication to give this type of therapy after that. And also for patients where there is MIVG therapy is not indicated, as we discussed earlier. Now, this is my last slide about PHEO. So these were the treatment recommendations for rapidly growing tumors or large tumors or symptoms related to the large tumor. We give chemotherapy, either IV or oral chemotherapy, or if there is still growth after that, then we discuss about the tyrosine kinase, and that will be another treatment options that can be given to these patients. If there is slow growth, but we still see some progression with elevated hormones, MIVG is what we used to indicate, but that say they're no longer using MIVG. There is another form of MIVG. It's not the one that was FDA approved, but that's something that work is ongoing to see what is the benefit, or Lutathera. Now, if there is not avid on MIVG, so there is other, and there's still tumors, the tumors are growing, so there is treatments similarly to what we discussed earlier with the sunitinib, cabozantinib, or axitinib, which those are drugs that are part of the tyrosine kinase, and as I discussed, those drugs blocks the blood vessel supply going into the tumor or clinical trial. So that's kind of like the indications on patients that have pheochromocytomas and paragangliomas. That say it's always important you discuss with your doctors what is the best treatment for your tumor. And now let's discuss a little bit about, these are the take-home points for PHEO, as these are rare cancers. They can be life-threatening because of the hormones that they produce and very elevated blood pressure that place a patient at risk to develop heart attacks as well as strokes. Genetic counseling is very important in all patients. We collect hormones either by plasma or 24-hour urine as well. CT and MRI is important to localize the tumor. DOTA scans help us as well to detect if there is any tumors outside of where the original, what we call primary tumor is found, but as well as to help us determine who can benefit from Lutathera. So it's important in patients that have this type of tumor. Blood pressure is one of the most important aspects in the management of these tumors, and blood pressure medications and what we call these alpha blockers. A name for that is called doxazosin or terazocin. Patients, male patients that have enlarged prostate, they may take terazocin. So it's kind of like in the same family, but that's the reason why it's very important to discuss with your doctor. So if it's localized, surgery is indicated, but if there is any more malignant pheochromocytomas and perigangliomas, then we need to discuss systemic therapy. And it's like any other neuroendocrine tumors, a multidisciplinary team is important also to discuss what is the best, what we think would be the best treatment algorithm for those patients, and guide also with our patients as well. Now let's discuss a little bit about whether my neuroendocrine tumor can be hereditary. And now we're going to talk about the role of genetic testing in neuroendocrine tumor management. So let's discuss a little bit about genetics 101. So I'm sure that sometimes you have heard whether the tumor is germline or whether it's somatic. So what is a germline mutation? So germline mutation is when there is either in the, either it comes from, or if it's a mutation that is either found in the egg or in the sperm. And because of that, these are called germ cells. So germ cells, they can have a mutation, and because these cells are important for reproduction, so if you were to have a kid, so there is a 50% chance that they can also have the mutation that may produce tumors, or patients can be susceptible for tumors. Germline doesn't mean germs, and that's kind of like, it's not because of germs. Germline is because of the germ cells, that like I said, is because of either from the egg and from the sperm, those are germ cells, and when they, they reproduce in order to form a baby in the future, so they can have a 50% chance that they may have a mutation. Okay, so somatic mutation is not located either on the egg and sperm. And because of that, somatic mutations, you never transfer those mutations to future generations, so to your offspring, so that will not happen. Somatic mutation is within the tumor. So whenever a patient has surgery and we do a biopsy, sometimes we send the tumor for molecular testing or genomic testing. That is sent for somatic mutation. And the reason why we're doing that is because we wanted to know whether there is a mutation that we can target with therapies, and that's why we do somatic mutation. But if we feel that there is a germline mutation, like I discussed, there is a risk that you can pass to your offspring. That's what means germline mutation, because from germ cells, then there is a different guidance that needs to be provided in those situations. So, and that's when we have the definition of what is cancer predisposition syndrome. Cancer predisposition syndrome is also called inherited cancer predisposition, hereditary cancer, it's the same, hereditary cancer predisposition, familial cancer predisposition, which is a genetic mutation that decreases the chance of developing cancer at the earlier stage. And that's what a cancer predisposition syndrome is, and it's called by germline mutations. Remember, germlines come from germ cells, which is the ova and the sperm, and then when they together form in the reproduction, there is a 50% chance in most of the cases that the offspring can have a mutation, and that's where that causes cancer predisposition syndrome. But also to keep in mind, not all germline mutations may have or predispose to develop tumors. And that's kind of like what we need to keep in mind about these cancer predisposition syndromes. Now, in terms of cancer predisposition syndromes involving NETs, so we discussed for PHEOs and PARAs, up to 45% of patients with PHEO and PARA may have a germline mutation, and those are the mutations associated with PHEO-PARA. Depending on what mutation is, then there is specific guidelines on how to do follow-up and surveillance. Now, for medullary cancer is another type of neuroendocrine tumors. Up to 25% of those patients may be hereditary, and that's what I discussed earlier about MEN2B, A or B. Now, for pulmonary or type MEC neuroendocrine tumors, up to 5% of patients may be associated with MEN1. So any patient that have a thymic or lunt neuroendocrine tumor, especially in an early age, we need to think about MEN1. Now, in patients with gastric and pancreas neuroendocrine tumors, up to 20% may be associated with a cancer predisposition syndrome, and among those can be MEN1, von Hippel-Lando, neurofibromatosis, and those are the ones I'm going to discuss. So as a summary, up to 10 to 20% of patients with gastric and pancreas neuroendocrine tumors may be associated with a cancer predisposition syndrome, and those are MEN1, VHL, neurofibromatosis type 1, or tuberous sclerosis. We're going to discuss the most common in the next few minutes. And as we discussed earlier, up to 45% of you para may have a cancer predisposition syndrome too. So these are the difference between MEN1 and MEN2. So MEN1, and that's what I'm going to focus about this because this is not applicable to you, any of you. If there is any question, please don't hesitate to ask me after this meeting. But in terms of MEN1, the clinical manifestation associated with MEN1 is pituitary tumors, which is the tumors located, is the mother of all hormones, regulate the whole hormones, and is basically localized in the very center of the brain. And then we have also the parathyroid gland. So these parathyroid glands are responsible to regulate calcium as well, calcium in the body, and sometimes I can get calcium from the bones, and your calcium levels are very high in the system, and of course, pancreas neuroendocrine tumors, and we're going to discuss a little bit about that. Multiple endocrine neoplasias, you say multiple, so that's why it's called MEN1. There's many different tumors associated, so we discussed about the three important ones, but then there is also other tumors associated with MEN1, as we can see here. Some of them are less common than the others, but that's the reason why, just to focus on the lunt and thymic neuroendocrine tumors, there is an association with MEN1. We also have other, like the gastrinomas, or neuroendocrine tumors of the stomach as well. And we have different neuroendocrine tumors arising from the pancreas, and a lot of these neuroendocrine tumors produces hormones, and because they produce the hormones, they have symptoms associated with that. And usually whenever a patient has MEN1, we need to test also for genetic testing. We need to test for genetic testing and make recommendations based on one. If we think that somebody may have MEN1. So we discussed that pancreas neuroendocrine tumors is the second most common manifestation of the 80% of patients. They can have functional tumors. Functional mean they produce hormones, and they can be gastrinomas. Gastrinomas meaning that they produce a lot of gastric acid, and they may have symptoms related to that. Insulinomas, they produce glucose goes very, very low. And there is other hormones as well associated with these pancreas neuroendocrine tumors. Most pancreas neuroendocrine tumors, even not associated with MEN1, are non-functional, meaning they don't produce hormones, but up to 40% may produce hormones, as we can see here. And patients with MEN1 that have gastrinomas also, so up to 25% of patients with gastrinomas also may need to be tested for MEN1. It's also very important as well to keep here. If you were told I have a gastrinoma, so then it's important to be tested also for MEN1. Sorry. Then we have the thymic neuroendocrine tumor, which is more of the bronchial neuroendocrine tumors, which are more rare of the neuroendocrine tumors associated with MEN1, but there is still up to 8% may have a risk to develop these thymic neuroendocrine tumors or a lunt neuroendocrine tumors. And it's something that we need to keep in mind as well. Whenever we have these manifestations, we need to then discuss with your doctors whether this could be an association with a cancer predisposition syndrome, and then to work up accordingly. Some of these thymic or neuroendocrine tumors may also produce hormones that can cause symptoms. So depending if you have symptoms, then we need to test for those hormones. Treatment is very similar to what we discussed earlier to other lunt and thymic neuroendocrine tumors that is not associated with MEN1. Sorry. So why we need to test for MEN1? So it is important. Any index patient with clinical MEN1 so need to be tested for MEN1. Any first degree relative known to have MEN1 also needs to have any clinical manifestation of MEN1. They also need to be tested as well, even if they have symptoms or not. And any individuals with suspicious. Oops. Oh, it's my timing. Okay. Sorry. So just 2 minutes. Because I want to discuss about the other two, like von Hippel-Lindau. Up to 70% of von Hippel-Lindau may develop pancreas neuroendocrine tumors, and up to 25% may develop pheochromocytomas, as we discussed earlier. And there is different clinical manifestations associated with von Hippel-Lindau. And there is screening guidelines too, and follow-up as well. How do we follow these patients too? This information will be provided to you. But again, if you have any questions, I'm here until the end. Always answer any questions that you may have, but this patient needs to have a long-time surveillance with scans in order to detect earlier any of these tumors. Similar with NF1, there's patients with NF1 up to 1% or maybe have pancreas neuroendocrine tumors, as you can see, is very, very rare, and sometimes they can also present for pheochromocytoma and paraganglioma. They also have other clinical manifestations associated with NF1. Such as neurofibroma. So these kind of like the little lumps that you see in the skin, these are called neurofibroma. So they can have these optic gliomas as well, leash nodules. This is what is called leash nodules. It's kind of like these speckles that you sometimes see in the eyes. But there are different clinical manifestations. The reason why I'm mentioning this is because whenever we see these cancer predisposition syndromes, and there is an association with pancreas neuroendocrine tumors, there are usually other clinical manifestations. And that's something that my patients sometimes ask me, do I have MEN1? Do I have von Hippel-Lindau? But usually we see other clinical manifestations associated with neuroendocrine tumors. Usually it's not the only, neuroendocrine tumors is usually not the only clinical manifestation, and something to keep in mind. And with that, that's kind of like the same. This is kind of like a patient journey with MEN1. The most important to remember here is like any other cancer predisposition syndrome is a lifelong surveillance. And we do imaging studies, we do testing. There's challenges associated with that as well. Patients that have this cancer predisposition syndrome, there's a lot of challenges too, because even if they have the mutation, it's like when the evidence of tumors may present, how do we follow? If there is any other tumors as well associated with that, how do we treat it? How do we follow each one of them? And that's something that can be very challenging as well for the patient to have this cancer predisposition syndrome. Because I run out of time, I just wanted to discuss my last slide, which is there are specific recommendations for each cancer predisposition syndrome based on the risk of tumor development. We also have various guidelines have been produced for recommendations of screening and surveillance for this cancer predisposition syndrome, but there is also some challenges as well, because sometimes we don't know as well especially if we know that my kid may have the mutation and is 5 years old, when is the exact age to do these CT scans and follow-up? And that's a question that we sometimes do know with this cancer predisposition syndrome. There is no biomarkers, there is no blood test that can tell us either when is the right time to start doing surveillance with scans. And that sometimes causes a little bit of anxiety too, but at the same time, this excessive testing and screening can create also anxiety by itself, because sometimes we do too many scans, too many follow-ups, and it's like, sometimes do we overkill by doing that, and that's sometimes what we're trying to understand about this cancer predisposition syndrome associated with MEN1. And then we have better therapies too. Do we have any drug that can prevent the development of these tumors? And that's something that we're working. We don't have anything as of now. That's the reason why the best way to follow these patients is with frequent scans, and then do an intervention whenever we see it. Sometimes what happens is that we have a patient already that have tumors everywhere, and that's what we see with neuroendocrine tumors. By the time a patient is diagnosed with neuroendocrine tumors, we see already lesions in the livers, and what are we doing to those situations, and how do we follow my offsprints with genetic testing as well for surveillance too. But that's still a lot of questions to answer that we need to answer, and hopefully maybe 2 years from now, a few years from now, we can have more answers to then make more treatment recommendations that is needed for each patient as well. And with that, I would like to thank you and NCAN for allowing me to talk about PHEOs and PARAs and neuroendocrine tumors associated with cancer predisposition syndrome. Thank you.